Welcome to the deep dive. Today, we're getting really granular, looking right into the nerve center of the GI lab, the endoscopy tower.
Hmm.
And this deep dive, it's really for you listening, the technicians, the nurses running these systems daily. We're pulling insights from top sources, especially Dr. Raju's video content, focusing on those, absolutely critical setup details.
That's right. I like thinking of it this way. If the scope is the ship on an internal voyage,
Mm.
well, the tower is mission control. It's this whole stack delivering light, gas, water, suction, images,
Yeah.
everything.
Yeah, mission control. I like that.
And our goal here isn't just like listing parts. It's about seeing how careful setup, really meticulous setup, right down to the tiny details, directly impacts how well things go.
Mm.
Safety, comfort, clear views.
It's like you said, a high-functioning team. Every single unit has to be perfectly in sync.
Oh.
So where do we start? Top of the stack? The light source?
Let's do it. The vision engine, the light source. Its main job, obviously, is like headlights for the scope.
Mhm.
But there's a key maintenance point here that often gets missed. Well, the sources really stress this. Setting brightness to Drenny? Automatic is standard, sure. But you have to check that lamp life gauge.
Sure.
Dr. Raju and others emphasize that when those lamps hit the 400 to 500 hour range, you should be thinking about replacing them proactively.
400 to 500, why so early? I mean, why not just wait until the bulb actually, burns out?
Well,
Seems like it would save money.
It's a safety and quality thing, really. It's
Yeah.
not just about it suddenly going dark.
Okay.
Xenon lamps, they degrade.
Mm-hmm.
The light output drops, the color temperature shifts.
Mm-hmm.
It happens gradually as they approach the end of their life.
I see.
So waiting for it to completely fail mid-procedure.
Yeah.
That means stopping everything, delays, stress for the patient. That's bad news.
Yeah.
But even before that, a dim or off-color light,
Yeah.
that can genuinely affect the doctor's ability to spot subtle things, tiny tissue changes, maybe a small lesion.
Yeah.
So replacing it early ensures you've got consistent, true color the whole time.
Okay. That makes total sense when you put it like that. It's not just about the light being on, it's about the quality of the light.
Exactly. Big difference for inventory management, too, knowing that ahead of time.
All right. Next down the stack, making space to see. The air or COOO core low, this is where patient comfort really comes into play, doesn't it?
It really does. We need to gently inflate the organ, right?
Yeah.
To navigate safely. Room air works, has been used for years,
Mhm.
but COO air, carbon dioxide, is
Oh.
definitely the preferred standard now. And it's all about patient comfort afterwards.
Because it absorbs faster.
Way faster. The body absorbs co-euro something like 150 times faster than the nitrogen in room air.
Wow, 150 times.
Yeah. So you get much less of that post-procedure bloating, the
Uh-huh.
cramping. It really makes a difference for the patient. It's like you said, the guest that leaves quickly.
Right. But for the tech setting up, that means a different switch needs flipping, depending on what you're using.
Absolutely critical difference. If you're hooking up a co-aero tank, which is common now, you must set the processor's built-in air function to standby.
Standby. Okay.
If you leave it on, you're essentially trying to pump gas from two sources.
Right.
Bad pressure control.
Got it. And if you are using the room air pump built into the processor,
Then you leave the air function on. It's a tiny setting difference, but crucial for managing pressure correctly.
and that small step, choosing co-euros and setting it up right, avoids patients feeling miserable afterwards, maybe even calling back or heading to the ER.
Precisely. It's turning a technical detail into, well, compassionate care.
Okay, moving down. The video processor, the image translator, this is the brain, taking the camera signal and putting that live image on the monitor. What's the absolute can't skip setup step here?
Oh, easy. The white balance check has to be done before every single case. No exceptions.
Why is that so vital?
Because it calibrates the whole system. It tells the processor what white looks like under the current room light through that specific scope. It ensures the colors you see on screen are true to life.
And if you skip it,
Colors get skewed. Often things look too red or too yellow. Imagine the physician is looking for a tiny bleeding point or a subtle flat polyp if the color's wrong.
they could miss it entirely.
Exactly. It's fundamental for accurate diagnosis, not just about a nice picture.
Right. And the source material also mentioned this processor handles other modes, like trans-elimination, US.
Yes, transillumination, that's often for PEG tube placements, feeding tubes. The processor has to manage the light so it shines clearly through the abdominal wall, helps guide where to safely place the tube.
Ah, okay.
And for EUS, endoscopic ultrasound, the processor needs calibration too. It's handling that ultrasound signal coming from the special EUS scope, merging it with the visual image. Often needs different output settings for the separate EUS machine. So yeah, the setup can change quite a bit depending on the procedure type.
Okay, so we've got light, we've got space, we've got accurate images. Now, keeping the view clear, water jet pump and suction. What are the common pitfalls here during setup?
For the water jet, the precision rinse, it's mostly about the water itself, using a clean, dedicated canister, and crucially, labeling it. Date and time it was opened, that's basic infection control.
Okay. Tubing connected properly through the pump.
Right, making sure the pump recognizes the tubing, pressure's okay. For suction, it's all about the vacuum seal.
The canister lid.
Yep. Check that lid, make sure it's tight, no leaks. Any air leak there means less suction power at the scope tip.
And that suction isn't just for liquid, right?
Correct. It also removes the insufflated gas, that's COA, or air. That helps visibility and patient comfort by reducing pressure. Before you start, you got to test it. Block the suction port on the scope connector, make sure you feel strong, continuous suction.
Makes sense. Test the seal. Now, while all this physical stuff is happening, there's the computer system quietly logging everything, the digital logbook. It's doing more than just name and DOB these days.
Oh, much more. This is where the procedure gets documented as, well, a quality procedure. It logs who's in the room, the scope model, yes, but also key timings.
Like insertion time, withdrawal time.
And critically, for colonoscopies, the exact time the cecum is reached, the very beginning of the large intestine.
Why is that specific time so important? Seems very specific.
It's the gold standard for proving a complete colonoscopy.
Yeah.
Reaching the cecum means you've visualized the entire colon. That timestamp isn't just for the patient's chart.
No?
No, it's used for quality audits, for accreditation, sometimes even for billing and reimbursement. If that cecum time isn't documented accurately, the whole procedure's thoroughness can be questioned. It reflects on the physician, the whole unit.
Wow. So the tech clicking that button, confirming that time, is directly tying into the unit's overall quality metrics. That's quite a responsibility.
It really is. It connects the setup work directly to validated outcomes.
Okay. And speaking of efficiency, sometimes there's the scope guide, the internal GPS.
Yeah, becoming more common. It uses a weak magnetic field, creates a live 3D map showing exactly where the scope is inside the patient and how it's looping or not looping.
Like a car's GPS.
Kind of. For the doctor, it helps avoid creating those big painful loops in the colon. It helps them advance more directly.
And for the patient.
Less looping means less discomfort, potentially less sedation needed, and usually a faster procedure overall. Just makes navigation smarter.
Got it. Okay, all these details lead us to what you called the quiet choreography, that morning setup checklist. Let's revisit the irrigation setup. You mentioned connection points can be tricky.
Yes, this is a really common spot for errors if you're not careful. The tubing comes to the water canister, goes through the pump, and connects to the scope. For most standard adult scopes,
Yeah.
it connects to a specific port called the auxiliary water connector. It's separate, designed just for that flushing water.
But not always. You mentioned smaller scopes.
Exactly. Pediatric scopes or those ultra-thin ones, they're built smaller, often without that separate auxiliary channel.
So where does the water go then?
For those, the water tubing connects differently. It feeds water through the biopsy channel instead. So if you mix that up, connect the wrong tube to the wrong port, you either get no water jet when you need it, or you block the biopsy channel so instruments can't pass through. You absolutely have to know your scope model and where that water connects. It's fundamental.
That's a super specific but clearly critical detail. Okay, now the big one, the safety pause. Foot pedal placement for the water jet. This sounds serious.
It is. This is one of the highest risk parts of the setup if you get it wrong. The absolute rule, driven by safety, is keep that water jet foot pedal far away from the endoscopist initially, several feet away.
Why? Why not have it right there, ready to use?
Because if they accidentally step on it too early.
When the scoop is still in the throat.
Precisely. If the scope tip is still in the pharynx and that pedal gets pressed, pressurized water shoots right towards the airway, the vocal cords.
Oh, wow.
That causes aspiration. The patient inhales the water. It can lead to serious pneumonia. It's a genuine emergency, a massive risk.
So you, the tech, you physically keep that pedal out of reach until the doctor says they're past the throat, past the upper esophageal sphincter.
Yes. Only once the scope is safely down in the esophagus and the airway is protected, then you move the pedal into position. That deliberate pause, that physical placement, it's a critical safety intervention. It prevents a potentially catastrophic complication.
That's incredibly important. Okay, so everything's connected, Keo, Euro, water, suction caps are tight, air water buttons are on. What's the final check before go time?
The full systems check. Right before the scope touches the patient, you test everything.
All three main functions.
All three. Test the suction, cover the port, feel the vacuum, Test the air, see a puff of air from the tip. Test the water jet, see a stream of water. You're confirming the whole system. Insufflation, rinse, vacuum is working together perfectly, ready for launch.
Fantastic. So, bringing this all together, then, every successful procedure, every internal voyage really depends on these three systems working in perfect harmony.
That's the core of it. Insufflation, whether it's TOROs or air. The auxiliary water jet for that targeted rinse. And the suction system to clear the field and reduce pressure. Get those three set up and maintained perfectly.
And the physician has what they need for a safe, clear look.
Exactly.
And we've really seen how those small details, labeling the water bottle with the time, thinking about that 400, 500 hour mark for the lamp, carefully placing that foot pedal, they aren't just tasks on a checklist.
No, not at all.
They're the moments where technical precision turns directly into safer, more comfortable, more compassionate patient care.
Well said. It's how we turn that, dark internal space into a clear, navigable landscape.
Which leads us to a final thought for you, our listeners, to take away.
Hmm.
If procedural success is measured by the quality of that voyage,
Yeah.
think about the computer's logbook, that SECUM time we talked about. Consider how that single digital timestamp isn't just a record for the chart. It stands as the ultimate measurable proof of a thorough, high-quality procedure. The validation of the entire team's careful work right there in the system. Something to think about.